Chapter 31 will discuss disorders of ventilation and gas exchange. So, um, what we're going to talk about here are really disorders of ventilation and diffusion. So, ventilation, the definition of that is movement of atmospheric air into the alveoli for gas exchange. So, in the picture, here's your alveoli, and you can see here's ventilation, just that movement of air in and out of the alveoli. Gas exchange of O2 and CO2 happens between the air that gets into the alveoli and the blood supply. So you can see that here we have capillaries that travel and kind of wrap around the alveoli, and that is where the gas exchange occurs. Diffusion is that movement of O2 from the air in the alveoli into the blood in those pulmonary capillaries, as well as the movement out of CO2. So for this to happen, both for gas exchange and diffusion to occur, we need an adequate blood supply as well as contact of that blood supply with those ventilated alveoli. So many of the disorders we're going to talk about today will disrupt some portion of that normal ventilation and diffusion. So things that maybe reduce ventilation by obstructing airways, or things that disrupt gas exchange because of problems with blood supply or a loss of surface area between the alveoli and the capillary, or things that disrupt diffusion, like maybe an increase in distance between the alveoli and the capillary, or changes to the amounts of O2 or CO2. Another thing to understand here is that the diffusion of O2 occurs less readily than the diffusion of CO2. So we will see conditions where we have hypoxemia without an increase in CO2 because CO2 moves much more easily across those membranes than O2 does. So we talked about this in class already, but I'm just going to reiterate some of the ventilation and perfusion ratio information. So we'll do this in relationship to kind of the picture on the side, and this is also in your reading. So the top picture, or A, shows normal healthy lung, the normal ratio of ventilation and perfusion that we see. So again, here's our alveoli. And here's that capillary and blood supply moving from deoxygenated to oxygenated blood. So in through the pulmonary artery and out through the pulmonary veins after it has left or discarded its CO2 and collected O2 to then move into the left heart for circulation to the body. So this is that normal process where we have good ventilation, air moving in and out with a nice open alveoli, and we have good perfusion, no constriction of that blood flow, no increase in distance for diffusion, normal healthy looking ventilation perfusion ratio that we see in a healthy lung. In B, this is an instance of what we call low ventilation or a shunt. And in this case, in a shunt, the perfusion far exceeds our ventilation. So you can see in B, we have still good perfusion. That blood is flowing just fine past that alveoli, no problem there. But what we have is a blockage in the alveoli itself, or the alveolus. So maybe a mucus plug, or maybe a tumor, something has blocked that alveoli, completely obstructing its ability to ventilate. So that blood just continues to pass by that completely obstructed distal airway without discarding its CO2 or picking up any O2. And so that blood that passes through here remains deoxygenated as it travels to the rest of the body. So you can see that significant kind of difference in color too, where we do not have much increase in oxygenation. So things that can cause a low ventilation situation because of blockage of the alveoli are things like pneumonia, where you might have large amounts of mucus production. Atelectasis, which we'll talk about in this presentation, which is a collapse of alveoli, can cause this. tumors, mucus plugs, anything again that will block that alveoli, significantly reducing ventilation. We can also get high ventilation to perfusion ratio situations. We call that dead space. And in this case, our ventilation far exceeds perfusion. So for some reason, we've got a significant reduction in the blood supply to the alveoli. So you can see that in C. Our alveoli remains normal. Air is traveling in and out just fine. But here is our perfusion past the alveoli. And you can see that there is a blockage right here in that blood supply. And so that blood is not passing by that alveoli to pick up O2 and to discard its CO2. So we call that dead space because this alveoli, while well ventilated, is not capable of engaging in any gas exchange because of the lack of perfusion. So again, shunting in B, dead space in C. And the final picture here is in D is something that we call a silent unit. And that occurs when we lose both perfusion and ventilation. So absence of both ventilation and perfusion. This can happen in a pneumothorax. It can happen in severe acute respiratory distress syndrome or ARDS, which we'll talk about. So you can see we have blockage of both the blood flow and of the alveoli. Again, that's called a complete silent unit. So the gases of respiration, and these should be familiar to you, are really the primary function of the respiratory system, and that is to remove CO2 and to add O2. Insufficient exchange of gases can lead to hypoxemia or a drop in oxygen, and hypercapnia, a relative increase in CO2 in the serum. So we'll discuss hypoxemia a bit. Hypoxemia is the result of inadequate oxygen in the air, or it can result from a severe disease of the respiratory system. It can happen as a result of dysfunctions within the neurological system that would normally drive that respiratory system. And it can also happen because of significant alterations in circulatory or blood flow function, things like heart failure or maybe severe vasoconstriction would be some examples there. Some mechanisms whereby this happens, and we'll talk about these a bit more when we get to respiratory failure as well. But one major mechanism is hypoventilation, either not ventilating the small airways or maybe loss of ventilatory drive in general. It can be caused by the impaired diffusion of gases. So there's some problem at that alveolar capillary meeting point that reduces that diffusion of gases. That can be the result of not having enough oxygen in the air to create a adequate diffusion gradient to push oxygen into the blood. Of course, inadequate circulation of blood through those pulmonary capillaries. And then also something called mismatching of ventilation and perfusion. Again, we're going to talk about this more when we get to some of the specific disorders as well as to respiratory failure. So the clinical manifestations of hypoxemia are kind of directly related to the, level or severity of this drop in oxygen. So thinking about how these clinical manifestations arise, one thing to remember is that there are certain tissues within the body that have a greater need for O2. So a lot of the time, the clinical manifestations or symptoms that we see will start in those tissues or be caused by impairments in those tissues that have high levels of need for oxygen. So those tissues tend to be the brain, the lungs, and the heart. So the other thing is that the clinical manifestations are from low O2, but also from the compensatory mechanisms that happen when oxygen is low. So when we look at some of the hypoxemia clinical manifestations, one of them is, of course, metabolic acidosis. And I'm sure you recall by now that that has to do with that shift from aerobic to anaerobic metabolism with a resultant increase in lactic acid. That's the increase there. But when discussing things like compensatory mechanisms, they're largely driven by sympathetic nervous system activity. So that produces things like an increase in heart rate, peripheral vasoconstriction, diaphoresis, and perhaps a mild increase in blood pressure. We might also see a slight impairment of mental performance, again, because the brain is highly sensitive to needs of oxygen. So we see impairment there first. If we don't correct hypoxemia and it becomes more pronounced, we may see further deterioration of mental performance. So things like confusion, personality changes, restlessness, and agitation are very common with hypoxemia. Some people may become combative, and we may start to notice things like uncoordinated muscle movements. If hypoxemia persists, the patient can experience things like reduced level of consciousness, further impairment of cardiovascular function, um, and things like that. For some people, they experience what we call chronic hypoxemia. Manifestations of chronic hypoxia may be insidious in onset and may be attributed to other causes. And because they're slower in their development, the compensation mechanisms might overall mask the condition. Um, so things like pulmonary vasoconstriction might occur as a local response to alveolar hypoxia. This can increase things like the pulmonary arterial pressure and improve the matching of ventilation and blood flow. And so that's one of the kind of compensatory things we might see in patients with chronic hypoxemia. They may also develop things like increased ventilation, so their respiratory rate may increase and they might attempt to breathe more deeply, maybe using things like accessory muscles. Again, they have more pulmonary kind of vasoconstriction as that sort of local response to sort of rematch ventilation and blood flow. They may have an increased production in red blood cells, so they may have a significant rise in their hemoglobin and hematocrit, and they may develop things like cyanosis due to lack of oxygen. So the diagnosis and management of hypoxemia, usually with hypoxemia are pulmonary artery oxygen partial pressures on arterial blood gases are between 80 to 100 millimeters of mercury. And our SpO2 is normally 90 to 100% on a pulse oximeter. So if those are the normal values, hypoxemia is diagnosed when we drop below those normal ranges. And again, the level of drop away from normal usually speaks to the amount of and severity of the clinical manifestations that we see. One other diagnostic criteria that I'll mention here, and we'll talk about again when we get to um, acute respiratory distress syndrome or ARDS later, is something called the PF ratio. It's the ratio of arterial PaO2, so that 80 to 100 millimeters of mercury in the blood, to the fraction of inspired oxygen. So I mentioned in class that the FiO2 of room air is about 21%. So someone breathing room air and with a normal PaO2 of maybe 90 would be, 90 over that, about 21%. So that's with no intervention. That's with normal arterial PaO2. But this is really helpful in talking about the severity of ARDS because ARDS patients are extremely difficult to oxygenate even with really high rates of supplemental oxygen or what we call, really high levels of fraction of inspired oxygen. So ARDS patients are being given oftentimes, 100% oxygen rather than the 21% we get, on normal room air. And yet they're not satting anywhere near normal. So their pulse oximetry is really low, but on arterial blood gases, we may be seeing, oxygen pressures well below 80. So for a normal person, this ratio would be about 400 to 500 millimeters of mercury. And you can see in the table over here, someone with ARDS, even what we would consider mild ARDS, that ratio drops down to 200 to 300. And when someone has a severe case of ARDS, it can get less than 100. People who have ARDS that is this severe based on PF ratio have mortality rates around 50%. So it's a good, again, a good kind of diagnostic tool to think about the severity of ARDS in relationship to how well we can oxygenate these patients. So treatment of hypoxemia is really to try to treat the underlying cause of the hypoxemia while also increasing that O2 gradient. And we do that with supplemental oxygen. So if you think about what's happening there, right? If someone is breathing supplemental oxygen, they're getting oxygen that is above that, 21% inspired air that we get with room air. Now entering the alveoli is air with a much higher level or number of O2. And so that sets up a concentration gradient where we have a lot more O2 available for diffusion into the capillary beds. And because there's so much more, it moves much more quickly down its concentration gradient. So supplemental oxygen is very helpful in treating hypoxemia by increasing that O2 gradient at the site of gas exchange. Hypercapnia is increased arterial PCO2. Hypercapnia is usually caused by hypoventilation, or it can be caused by a mismatching of ventilation and perfusion. And we'll kind of talk about both. Remembering that diffusing capacity of carbon dioxide is 20 times higher than that of oxygen, meaning carbon dioxide moves much more readily across a concentration gradient than oxygen does. Okay. So hypercapnia without hypoxemia is usually observed only when we have significant situations of hypoventilation. So if someone isn't really breathing at all, either because of a injury to the central nervous system that has dropped their respiratory drive, or because they maybe have paralyzed muscles of their trunk that are preventing them from being able to ventilate, those are people who usually develop both hypercapnia, and that usually happens first, followed by hypoxia. If we have ventilation perfusion mismatching, hypercapnia is usually accompanied by a decrease in arterial PO2 levels, but as long as the pH stays within normal range, the only complications we really see in that case are the ones that result from hypoxia. So having said that, some of the effects that we can get of hypercapnia are things like acid-base imbalance, so a decreased pH, especially if PCO2 rises, otherwise known as a respiratory acidosis. This can start to affect things like our kidney function, our nervous system function, as well as our cardiovascular function. We diagnose hypercapnia usually via arterial pH and ABGs, but we also in clinical settings now have CO2 detectors that can detect elevated levels of expired CO2. So usually we put these things on maybe patients who are on patient-controlled analgesia, who are getting high doses potentially of narcotics or sedatives to monitor them for increases in CO2, because as we mentioned, CO2 in a patient that's hypoventilating rises first. So we can detect a drop in respiratory drive or potential for respiratory failure much earlier monitoring CO2 than we can monitoring O2. The treatment of hypercapnia is really several goals here. So one is to decrease the overall work of breathing. That's what WOB stands for. So decrease the work of breathing and also try to improve that ventilation perfusion balance, whether it's by increasing ventilation, increasing perfusion, whatever we need to do to bring that back into balance. We sometimes with these patients use maybe nocturnal negative airway pressure. So this would be a machine to help them breathe at night. It can help to kind of reduce sort of the overall fatigue of work of breathing. Or we may use continuous positive airway pressure through a machine that we use maybe during the day, again, also to reduce kind of that overall work of breathing. Sometimes with these patients, we use things like respiratory muscle retraining to try to strengthen the muscles in the chest or around in the trunk to assist with breathing. If hypercapnia is severe and acute, ventilation may be required to manage this condition. So I had mentioned work of breathing or WOB, so I just wanted to stop and kind of give you what the symptoms of work of breathing are. So what it would look like if you had a patient who was, working really hard to breathe. It's important to be able to recognize this because, as I mentioned kind of in the last slide very briefly, this kind of constant increased work of breathing can be very fatiguing for patients. Oftentimes, if this gets significant enough, they will not be able to maintain this kind of constant high work of breathing. Those muscles will fatigue. Their respirations will become, less deep, much more shallow. And kind of start to slow down. It's not something people can often maintain for long periods of time. So again, really good to be able to recognize when work of breathing is really high. So these are things like significant shortness of breath, diaphoresis, something called pursed lip breathing, where someone is pursing their lips, especially as they exhale. Tachypnea or bradyapnea, if work of breathing goes on and on at a high rate for a long time, respirations may actually start to decrease as that person just kind of starts to fatigue. And that might manifest too as a really irregular breathing pattern where they kind of speed up and slow down as they're trying to sort of conserve that energy. They often use accessory muscles, so you'll see movement like in the abdominal muscles or maybe in kind of the shoulders or in the neck as they try to assist the muscles of their chest through that work of breathing. They often get tachycardic, again, things like abdominal breathing, and they may develop cyanosis. So now we're going to talk about some of the different lung disorders. So we're going to start with disorders of lung inflation. So things that cause disorders of lung inflation or conditions that produce lung compression or lung collapse. So compression of the lung might be caused by an accumulation of fluid in the intrapleural space. And I have some images coming up that will kind of show you what that means and where that space is and how it causes this. We can also get complete collapse of an entire lung or portions of a lung, such as in cases of pneumothorax. Or we can get collapse of segments or portions of the lung that we see in a condition called atelectasis. So some of these things are caused by disorders of the pleura. So the pleura, what we see here outside of the lungs, we see the visceral pleura, which is directly covering the lung tissue itself. And then we see the parietal pleura, which is a kind of fibrous encasing or kind of outer coating of the lungs. And between the visceral pleura and the parietal pleura, we have something called the pleural space. And that space is relatively narrow, has a small amount of fluid in it, and that fluid helps to reduce friction as the person's lungs expand, which might cause kind of rubbing of those two like pleural linings together. So we have this, again, small cavity here with some fluid in it. And the purpose of that is to provide kind of some lubrication and smooth movement as those muscles, as those lungs expand. Okay. But we can get disorders or things that affect the pleura and that pleural space. So one is something called a pleural effusion, and that's an abnormal collection of fluid in the pleural cavity. So in that pleural space between the visceral and parietal pleura, we get a significant collection of fluid there. Things that can cause effusions, they can be caused by congestive heart failure, renal failure, and liver failure. Anything that causes an overall kind of increase in stored fluid in the body can cause this. Another common cause is malignancy. We see a lot of pleural effusion in patients with things like breast cancers, lung cancers, various cancers can cause pleural effusions. Other things that can cause this are infectious processes like bacterial pneumonia or viral infections that cause kind of like purulent exudates to build up in that pleural space. Usually we treat these by a procedure called thoracentesis, where we insert a needle through the skin, usually on the back. We usually use ultrasound to guide that needle towards that pleural space. Once we get the needle inside the pleural space, we simply aspirate that fluid until it's largely removed. A patient with a pleural effusion might have pain in their chest, especially on inspiration. They're usually short of breath, increased work of breathing. They may be having trouble maintaining their O2 saturations because of an inability to properly kind of expand the lungs and ventilate well. And those patients, especially if they're experiencing severe respiratory symptoms, might require thoracentesis or removal of that fluid to relieve the symptoms. Patients also can get something called hemothorax, and that is a collection of blood within that pleural cavity. Some common causes of hemothorax are things like chest injuries or chest surgeries. Hemothorax is pretty common after things like open heart surgery or lobectomy or surgeries directly on the lungs. They can also be caused sometimes by malignancies and potentially by aortic aneurysms or aneurysms of other kind of large vessels in and around the lungs. The treatment is usually through drainage via chest tube, so a tube that's put in through the chest into that pleural space to help drain that fluid. You guys will learn more about chest tubes in 3015 and 3016 next semester. Another pleura disorder is something called a pneumothorax. This is when we get air in the pleural space. So that pleural space starts to significantly fill with air. And as it fills with air, it pushes against the lung tissue and can cause it either to partially or completely collapse. These things can happen spontaneously. We do sometimes see spontaneous pneumothorax. People most at risk for spontaneous pneumothorax are usually young men who are kind of taller, often get pneumothorax, tall, thin men. But they can also be caused by things like injury to the chest or to the major airways. So if we have like maybe something that maybe punctures through that parietal pleura and allows air to kind of travel in, that can cause a pneumothorax. There's also something called, and I have some pictures coming up on the next slide, a tension pneumothorax. And this is a life-threatening condition where we get significant increase in the pressure within the pleural cavity, and that can start to impair both respiratory and cardiac function. So if we have tension pneumothorax, we need to relieve that pneumothorax, usually with a chest tube to prevent any life-threatening complications. The final disorder of the pleura is something called pleural inflammation. We also call that pleuritis. That's when this space doesn't necessarily expand, but it becomes very inflamed. And so now instead of that nice smooth movement of those two fibrous linings, they're kind of almost rubbing together because they're so inflamed. And so our patient will have chest pain. And then we also hear something called a friction rub if we take out our stethoscope and auscultate the lungs. And it kind of sounds like almost a squeaky door opening and closing as those inflamed tissues rub against each other with respiration. Here are some pictures of the pneumothorax, specifically, as I mentioned earlier. So this is an open pneumothorax where there's a direct puncture into that pleural space that causes all this air to fill it up and press that lung tissue. There's the lung way down here, right? All kind of collapsed down. Um, and so you can see there's that kind of significant loss. This is a tension pneumothorax, um, where we get kind of this overall like increase in pressure within the uh, you know, pleural cavity, causing decreases in respiration and cardiac function. So with pneumothorax, some of the signs and symptoms that are important to watch for are things like chest pain, increased respiratory rate, and dyspnea. We sometimes see chest asymmetry, especially when someone's breathing in and out. You see one side that's not expanding really at all with inspiration. That could be an indicator of pneumothorax. If we auscultate the lungs over a pneumothorax, we would have either decreased or absent breath sounds. And especially in tension pneumothorax, we might get what we call tracheal deviation. So the trachea itself, and you can see this kind of on the patient's neck, you'll see instead of the trachea being midline, it shifts over, usually over and away from the side of the tension pneumothorax, especially on expiration. You can kind of see that happening here as it pushes kind of over. Okay. So tracheal deviation is an important sign of tension pneumothorax. We often see decreased cardiac output, again, especially with tension pneumothorax, and it can cause backup of blood. So we might see jugular venous distension. They're often hypoxic. We diagnose pneumothorax usually on chest x-ray. So we'll do a chest x-ray and we'll see that kind of collapse of the lung. And the treatment here is usually a chest tube where we insert a tube to relieve that air inside of the pleural space, allowing that lung to re-expand. Then we'll talk about atelectasis. So this is when we get incomplete expansion of just a portion of the lung. So some common causes here are things like airway obstruction. So that can be something like maybe a mucus plug in the airway, or from lung compression that might occur in something like a pneumothorax or a pleural effusion. So compression, yeah, by fluid or maybe a tumor that might be compressing on the lungs, um, or any matter in the area surrounding the airway can cause kind of an obstructive atelectasis. And then also increased recoil of the lung that we see if we lose pulmonary surfactant. So this is something that can commonly happen maybe in premature infants who have a lack of surfactant production. There's also a significant danger of obstructive atelectasis occurring after surgery. That is a significant potential complication that we watch for and manage in post-surgical patients. So we do this by making sure those patients are coughing and deep breathing so that we prevent any obstructions to those airways and make sure that they're all expanding and staying open. So the clinical manifestations of atelectasis are things like tachypnea and shortness of breath. Patients may become tachycardic as they try to compensate for a drop in oxygen levels. They may become cyanotic and hypoxemia. Their chest expansion may decrease as well as their breath sounds. So sometimes you put your stethoscope on a patient, especially maybe at the bases of the lungs, and you hear very little kind of air movement over certain portions. That can be a sign of atelectasis. In severe respiratory distress, and especially in young children, we might see intercostal retractions. Usually the signs of distress are directly proportional to the extent of lung collapse. So very small areas, you might not see very many outward signs and symptoms at all, but as more areas are affected, the signs and symptoms will get worse. Diagnosis and treatment of atelectasis, we watch for those clinical manifestations and then verify atelectasis maybe on chest x-ray or on CT. We want to try to reduce any airway obstruction or compression, so we need to take away the cause of the atelectasis. Some common treatment methods we use are ambulation, so especially maybe with our post-surgical patient or a patient with low mobility, we want to really kind of encourage early mobilization, early ambulation. That can be very helpful. We want to work with patients to do coughing and deep breathing exercises, And body positioning to facilitate lung expansion can be very helpful here. Making sure our patients are sitting up, making sure they're not in kind of one position for too long, whatever we can do to kind of, position the body in a way that maintains and facilitates lung expansion. And we can also use supplemental oxygen, especially, while we're working towards treating atelectasis, we may need supplemental oxygen to ensure that our patient isn't becoming too hypoxemic. So then we're going to move on to the obstructive airway disorders. And so these are usually these are disorders caused by things that limit expiratory airflow, so our ability to breathe out. So the common examples here are asthma and the chronic obstructive disorders like chronic bronchitis, emphysema, and cystic fibrosis. And so I'm going to leave it to your classmates for presentations on both asthma and on COPD. And I'm going to move on to some of the what we call diffuse interstitial lung diseases, or the ILDs. Okay. So by definition, this is a very diverse group of lung disorders that produce really similar inflammatory and fibrotic changes to the interstitium and intraalveolar septa of the lungs. So these are not disorders that directly affect the alveoli, like some of the ventilatory perfusion stuff or, our obstructive airway things. These are things that are affecting the tissues that are kind of surrounding the alveoli themselves, directly changing the actual lung tissue. Again, they cause at first usually inflammatory kind of changes that over time lead to fibrotic changes. Okay. And so in ILDs, the end result is usually what we term a stiff and non-compliant lung. They're usually classified as what we call restrictive lung disorders. That's in contrast to obstructive lung diseases, again, because the lungs are stiff and difficult to expand, but the airways themselves are normal and functioning. We just have stiff lung tissue that can no longer actively kind of facilitate expansion and ventilation. Interstitial lung disorders exert their effects on the collagen and elastic connective tissues that are found in kind of the delicate interstitium of the alveolar walls. And they're usually initiated by some type of injury to the alveolar epithelium, followed by an inflammatory process that involves the alveoli and the interstitium. That includes like accumulation of inflammatory and immune cells that cause damage to the lung tissue. And then over time, that lung tissue starts to become replaced. The normally functioning lung tissue becomes replaced with kind of fibrous or scarred tissues. So these are kind of chronic and gradual changes that over time reduce that overall compliance of the lungs. So just some types or examples of these ILDs are a condition called sarcoidosis. This also includes things that we term the occupational lung diseases. So these things are like coal miner lung, right? So somebody who has an occupation where they've breathed in toxins or chemicals or something long term that's causing this kind of chronic inflammation of the lung tissue. Other causes, hypersensitivity pneumonitis. So a hypersensitivity reaction where we have this kind of uncontrolled inflammatory process that can lead to fibrosis of the lungs, or lung diseases that are caused by exposure to toxic drugs can also lead to interstitial lung diseases. So we're going to move on to pulmonary embolism. And a pulmonary embolus is the development of a bloodborne substance that lodges in a branch of the pulmonary artery and obstructs blood flow. Okay. So you can see kind of on the picture over here, various pulmonary emboli in the pulmonary arteries. So in this first picture, you see you've got an embolus right in the main pulmonary artery. And because of the size and location of that embolus, we've lost blood supply to an entire side of the lung, right? We can also get smaller emboli, and you can kind of see that here, that lodge themselves further into the pulmonary artery circulation and just close off portions of the blood supply. So when we talk about signs and symptoms of pulmonary embolus, these often, the signs and symptoms that we see are directly related to the amount of lung tissue that has become the perfusion has become compromised by these pulmonary emboli. And so we said a blood-borne substance. So what do we mean by substance? Well, the most common substance is a thrombus that usually arises from a DVT or deep vein thrombosis. So someone develops a clot in their lower leg, and that clot embolizes and moves to the lung and lodges in the pulmonary arterial circulation. Other things that can do this are fat emboli. So these are usually mobilized from the bone marrow, usually after things like fracture or trauma to the bone themselves that causes an emboli to enter the bloodstream and lodge in the lungs. And another cause is amniotic fluid. So if there's after rupture of membranes, amniotic fluid can enter the maternal circulation at the time of delivery and cause a pulmonary embolus. So, as we mentioned, there's several things that can lodge, but again, the most common thing that will cause PE is deep vein thrombosis. Um, and this causes mechanical obstruction of the pulmonary circulation when that thrombosis embolizes and travels to the lungs. Okay. That obstruction causes reflex bronchoconstriction of the affected areas of the lungs. So if we lose blood supply, we also get bronchoconstriction. And now we've got wasted ventilation and impaired gas exchange. So if we have a PE, if you remember back to the ventilatory perfusion mismatch, we have blocked perfusion, but we still have potentially adequate ventilation or maybe reduced ventilation if we have bronchoconstriction. But remember, we consider that to be dead space, right? Because we have alveolar ventilation without perfusion, okay? Um, when we have an obstruction in the pulmonary circulation, that causes pulmonary hypertension or high pressures within the pulmonary artery. And that can in turn lead to right-sided heart failure because we get this kind of massive vasoconstriction, especially in the case of a large embolus. So those patients may develop signs and symptoms related to right-sided failure like JVD, um, peripheral edema, liver congestion. I have something on here called Virchow's triad. And this is the way that we talk about risk for the development of DVT. So it considers venous stasis, venous endothelial injury, and hypocoagulable states. So if those three things occur, that's our triangle, and they often lead to thrombosis. So venous stasis and venous endothelial injury can result from things like prolonged bed rest, trauma to the vasculature, surgery, childbirth, hip fractures, femur fractures, myocardial infarction, congestive heart failure, spinal cord injuries, people undergoing orthopedic surgeries, people with gynecological cancer surgeries are at particularly increased risk, as are really highly immobilized patients. People with hypercoagulability states, you may remember some of these, but I'll just give you a little reminder. So a lot of different factors can cause hypercoagulability. One is the presence of cancer cells, so malignancies. They significantly increase risk of thromboembolism. Other things are use of oral contraceptives, pregnancy, hormone replacement therapy, all implicated in that hypercoagulability. And again, if we have all three together, significant increase in thrombosis, significant increase in DVT, and resultant PE risk. So the clinical manifestations of a pulmonary embolus, again, they really depend on the size and the location of the obstruction. So some things that we commonly see might be chest pain, shortness of breath, and an increase in respiratory rate. The pain is often more severe on inspiration, especially patients with maybe mild to moderate sized PEs. We get impaired gas exchange with hypoxemia because of the drop in perfusion. Patients develop apprehension and anxiety. They may cough. They often get tachycardic, especially with hypoxemia, and they may develop rapid and shallow respirations. If someone has really a massive emboli that's present, they may collapse. They may have crushing chest pain. They may go into shock. They may have a rapid and weak pulse, a significant drop in blood pressure, signs of right heart failure like JVD, cyanosis, and diaphoresis. So diagnosis and treatment of PE, diagnosis is often by clinical signs, so patients that present with some of those symptoms that we just discussed. We might look at things like ABGs, and what we might see are things like hypoxemia. We might see hypercapnia. We can also do venous thrombosis studies to see if there's any deep vein thrombosis formation that could have become a PE. A couple serum tests that we do, or lab tests, are both troponin and D-dimer. A D-dimer testing involves the measurement of something called plasma D-dimer, and it's a degradation product of coagulation factors that may have been activated as the result of a thromboembolic event. So somebody who has a DVT will have these degraded coagulation factors that will show up in the serum as D-dimer. So that's what we're looking for there. We may also test serum troponin levels. Troponin is a cardiac marker, but those levels may increase with a PE because of stretching of the right ventricle if we have maybe a large pulmonary infarction. We may also do lung scans or chest CT, and we can also in some cases do a pulmonary angiography where we inject dye directly into the pulmonary arterial circulation. This is a less commonly performed procedure because it's quite invasive and can have more complications. But for maybe with patients with maybe severe signs of pulmonary embolus, we may perform this procedure because you may also be able to perform embolectomy or removal or breakup of that clot at the same time. So if we want to go ahead with that procedure in an attempt to kind of save this person's life, we may go ahead with pulmonary angiography in those cases. Other treatment measures, we may use thrombolytic therapy, so administering IV medications that would break up clots. But the other big piece here is really the preventative focus. So if we have somebody with, risks like venous stasis, hypercoagulable states, and maybe potential for endothelial injury, we really want to look at prevention of DVT formation. So things like pharmacological prophylaxis with maybe low molecular weight heparins or heparin infusions or warfarin or something to prevent that clot formation. Next, we're going to move on to pulmonary hypertension. So within the normal pulmonary circulation, it's really meant to be a relatively low pressure system. Those vessels within the pulmonary vasculature are really thin-walled. They can dilate and collapse and constrict based on various influences, but they are not designed to sustain significant high pressures like some of the other arterial systems within the systemic circulation that live under higher levels of pressure. So pulmonary hypertension is characterized by an elevation of pressure within the pulmonary circulation. So you can kind of see in the picture here, this is normal pulmonary circulation. So normal pulmonary arteries, kind of nice and open. And in pulmonary hypertension, we get this kind of constricting, which causes an overall increase in the pressure within the system. You can see in my normal patient, normal right and left heart. And in the patient with pulmonary hypertension, we see the significantly enlarged right ventricle in this patient because now we have a right ventricle that is working to push blood against circulation that is under high pressure, when again, it's normally not meant to be that way, right? So we can get primary and secondary pulmonary hypertension. So we're going to start with our discussion about primary pulmonary hypertension, its etiology and pathogenesis. So primary pulmonary hypertension is a disorder caused by changes in the arterial walls of the pulmonary circulation, leading to an increase in pulmonary arterial pressure, also called pulmonary arterial hypertension. So PAH is relatively rare, but it can be very debilitating and is very serious and can be life-threatening despite significant advancements in treatment. So patients with pulmonary hypertension have high rates of morbidity and mortality. So PAH includes abnormal proliferation and contraction of the vascular smooth muscles within the pulmonary circulation. We also see things like coagulation abnormalities. We see fibrosis of that intimal layer within the pulmonary arteries. And these things lead to obliteration and obstruction of the pulmonary arteries and arterioles in that pulmonary circulation. PAH can also result in progressive right-sided heart failure because, again, now we have a right heart that normally pumps against a low-pressure system, and now it's got to pump against a high-pressure system. It can cause it to fail. That can significantly reduce our cardiac output, and when very severe, can lead to death. This is a primary condition, and it usually is an inherited, I think it's an autosomal dominant trait. We see it more commonly in women. There is a difference in what we call penetrance, so people may have various levels of kind of symptoms with this, but again, as we mentioned, it's very debilitating, but luckily pretty rare to develop primary pulmonary hypertension. In secondary pulmonary hypertension, and this is most cases of pulmonary hypertension, there is some other underlying disease that is leading to the secondary development of pulmonary hypertension. So it might be obstruction of pulmonary blood flow, like we see in pulmonary embolism or PE. It might be the result of chronic hypoxemia that we see in conditions like COPD or the IDLs, or sometimes in sleep-disordered breathing. So patients with severe obstructive sleep apnea may develop secondary pulmonary hypertension. We also see this in cases of diastolic dysfunction, so diastolic dysfunction of the left heart. We see it in left heart disorders, so maybe left heart failure. We see it in mitral or aortic valve disorders, so those are the valves on the left side of the heart. Anything that can elevate those left-sided arterial pressures then can transmit that elevation and pressure back into the pulmonary circulation, causing pulmonary hypertension. The other thing to remember is that pulmonary vessels constrict in response to hypoxemia. The rest of the vessels in your body tend to dilate when we're hypoxemic. It is the opposite in the pulmonary vasculature. They constrict when we're hypoxemic. And so that's why conditions like COPD, IDLs, and sleep apnea that cause chronic hypoxemia also lead to pulmonary hypertension, because we've got kind of this constant constriction leading to high pressure within the pulmonary arterial system. So clinical manifestations of pulmonary hypertension. If it's primary pulmonary hypertension, we see persistent elevations in PA pressures or pulmonary artery pressures, but we see normal left ventricular or left arterial pressures. So because it's primary, the problem is directly within the pulmonary system itself. We don't see left ventricular side elevation and pressure. They often get significant shortness of breath that gets kind of worse and worse as the disease progresses, and also kind of this decreasing exercise tolerance as the disease progresses. Commonly, they develop right-sided heart failure, which leads to things like peripheral edema, fatigue, angina, and potentially syncope or near syncope, which is fainting. In secondary pulmonary hypertension, we have those same signs and symptoms of elevated PA pressures, but we also have all the clinical manifestations of the underlying heart or lung disease that led to the pulmonary hypertension. So the range of symptoms we see there can be much more significant because there's some other underlying disease. So diagnosis and treatment of pulmonary hypertension. If it's primary, we see hypertension in the pulmonary system with no cause of secondary hypertension. So we have to rule out any other cause of pulmonary hypertension to say for sure that it's primary in nature. Generally, the PA pressures are greater than 25 millimeters of mercury at rest, and I think greater than 30 when someone is exercising. We often look for these pressures and maybe the presence of things like right-sided failure using echocardiography. And to treat this, we usually use measures to maybe try to improve right heart function. So maybe reducing like maybe preload. And in that way, we're trying to reduce like kind of overall fatigue and peripheral edema. We often have to use supplemental oxygen in these patients to reduce hypoxemia. And in severe cases, these patients may become candidates for lung transplants. In secondary pulmonary hypertension, diagnosis is really kind of the same, echo, maybe radiography, but we do have a secondary cause in this case. So usually treatment is directed at relieving that underlying cause. So if it's an increase in left-sided pressure, we're going to take measures to try to reduce those overall pressures, right? If it's hypoxemia, we're going to try to reduce hypoxemia to lower that constriction. This is another condition, something called cor pulmonale, and this is right heart failure that results from some kind of primary lung disease that causes long-standing pulmonary hypertension. So it involves hypertrophy and the eventual failure of the right ventricle of the heart. Manifestations include the signs and symptoms of the primary lung disease and the signs of right-sided heart failure. So if we have a patient, and in the graphic here, it's a patient with long-standing COPD, so that's their primary lung disease, and that lung disease has caused a significant increase in the pressure in the pulmonary arterial system, probably because of things like hypoxemia, causing vasoconstriction. And so that constant increase in pressure then leads to this right-sided heart failure. So our patient will experience shortness of breath, which might be a manifestation they already had because of the lung disease. They're going to get peripheral edema. They may have hypoxemia, jugular venous distension from backup of blood from the heart, increased pressure in that venous system. They might become cyanotic, especially in the periphery, and they may develop hepatomegaly also because of that right-sided heart failure and backup of blood into the venous system. Your liver is entirely, entire blood supply to your liver is venous in nature. So there's venous to venous connection of blood through the liver. So hepatomegaly, because of that low pressure system, is very common in right-sided failure. Then we're going to move on to acute respiratory distress syndrome, or ARDS. Sometimes we call this ALI, or acute lung injury. There are a number of conditions that can lead to ALI or ARDS, and I think those are on the next slide. But regardless of cause, all of these things produce similar pathologic lung changes that include diffuse epithelial cell injury with an increased permeability of the alveolar capillary membrane. So what you see here is the alveoli, and here is the blood supply going past. And so many different things can cause this damage, but essentially what you're getting is kind of this protein-rich sort of edematous fluid that's kind of filling up these alveoli. You can get neutrophil infiltration from the blood supply as well. Different cellular debris and things can kind of build up. And all of these things cause like damage to the epithelial lining itself. And now this is hyperpermeable. And so we get kind of all of this sort of infiltration of fluid into the alveoli. So again, causes of ARDS, and these are just a few. Lots of things can cause ARDS. So things like massive aspiration of gastric contents. So causing, gastric contents into the lungs causes severe damage to the alveolar tissue. Major trauma can do this either with or without fat emboli. Sepsis is a very common cause of ARDS. That can be sepsis that's caused by pulmonary conditions, but it can also be non-pulmonary infections. Other causes are acute pancreatitis, various hematologic or blood disorders, major metabolic events, and reactions to some drugs or to toxins. So this is kind of the pathophysiological cascade of ARDS. So we start out with some kind of either direct or indirect lung injury. And this causes this kind of massive chemical mediator release. And that mediator release leads to two things. One is changes to the alveolar endothelial cells, and one is to overall endothelial changes. Okay. And so these overall endothelial changes happening in the vascular system can cause increased capillary permeability, which leads to interstitial pulmonary edema. So that fluid is entering the lung tissue itself. And that can also cause pulmonary vasoconstriction. So that can regionally alter the blood flow. So now we might have a reduction in blood flow to various regions of the lung tissues. Okay. So if we go back over to the other side, that mediator release is causing, again, changes to the endothelial tissues within the alveoli. So this causes shifting of fluids and proteins that can lead to cell damage, cell dysfunction. It can cause a thickening of the capillary membranes. It can reduce the production of surfactant. That surfactant reduction can increase things like surface tension and lowers overall lung compliance. The thickening of that capillary membrane can lead to more impaired gas exchange or more difficulty with gas diffusion. So as those tissues thicken, it causes like a larger distance over which that O2 has to diffuse, and that makes it really difficult for it to travel across the alveolar membrane into the capillary circulation. So both of these things, all those changes that happen both from alveolar endothelial changes and to the endothelial changes we see in the vasculature, lead to a whole bunch of alveolar collapse. They can lead to severe ventilatory perfusion mismatch. They cause a profound increase in the work of breathing. They can lead to interpulmonary shunting, and they can lead to hypoxemia. So this is kind of the final stage of all of these things. They lead to hypoxemia that is what we call refractory to supplemental oxygen. So in these ARDS patients, this hypoxemia, again, it's refractory to treatment with supplemental oxygen. So this leads to kind of this overall result of a decrease in that PF ratio. Because no matter how high that FiO2 is, again, we can be giving this patient 100% inspired oxygen, the PO or the partial pressure of oxygen in the arterial circulation remains very low. We just keep pumping oxygen in, and it's not reaching the circulation because of all of these pathophysiological changes to both the alveoli and the capillaries in ARDS. So many people with ARDS have also a systemic response because of severe hypoxemia that can result in multiple organ failure, especially of systems like the renal system, the gastrointestinal system, the cardiovascular system, and the central nervous system. So these folks' kidneys fail, their gastrointestinal system becomes necrotic, they get heart failure, loss of consciousness, all of those things go along with ARDS. Okay. So clinical manifestations. So usually the onset of ARDS is rapid, 12 to 24 hours after whatever cause has occurred. They get respiratory distress with signs of respiratory failure, which we'll talk about momentarily. They get severe hypoxemia with a reduced PF ratio, so high levels of FiO2 with low levels of, arterial oxygen. They get significant what we call bilateral infiltrates on radiography. And you can see that in the picture here. On the left are normal lungs. So all kind of open space for gas exchange. And this is an ARDS lung. So what all of this kind of white area is what we call infiltrates. So these are damaged areas where we probably have significant exudate formation in the alveoli and areas of really low perfusion and diffusion and gas exchange. So the treatment of ARDS is to try to do whatever we can to increase oxygenation. So oftentimes that is assisted mechanical ventilation using high concentrations of oxygen. It's usually required to try to correct the hypoxemia. And then we try to treat the underlying cause, right? So if this is caused by something like sepsis, we would give antibiotics to take care of the infection, whatever we need to do to take care of the underlying condition. And then we also want to prevent any further complications. So we mentioned things like multi-system organ failure. We don't want the kidneys to fail. We don't want the GI system to fail. So we're watching those things closely, trying to maintain oxygen levels at an adequate amount to prevent any further complications. And by doing those things, we also hope to decrease the overall mortality. But as I mentioned earlier in the presentation, mortality rates with severe ARDS are 50%, can be even greater. So this is not a condition that lends itself well to long-term survival if we can't reach those goals of treatment. So now we're going to move on to acute respiratory failure. There are two kind of general types of acute respiratory failure. There's hypoxemic failure that's due to a failure of gas exchange, and there's hypercapnic hypoxemic failure that's usually due to ventilatory failure. Okay. Some of the causes, so things like COPD or the ILDs, pneumonia and atelectasis, those are some things that can cause hypoxemic acute respiratory failure. Things like upper airway obstruction, weakness or paralysis of respiratory muscles or of the chest wall or the chest wall injury can cause hypercapnic hypoxemic respiratory failure. And things like pulmonary edema and ALI or ARDS cause significant impaired diffusion, which can lead to acute respiratory failure. Okay. So we're going to start by talking about hypoxemic respiratory failure. So in people with hypoxemic respiratory failure, there are two major pathophysiological factors that contribute to the lowering of arterial PO2. They are either ventilation perfusion mismatching or impaired diffusion. Okay. So in mismatching of ventilation and perfusion, this can be either caused by a loss of ventilation or a loss of perfusion. So either can cause this mismatch. We usually see pretty severe mismatching in patients with COPD. COPD also causes a lot of CO2 retention because we've lost a lot of gas exchange. And so the CO2 retention seen in mismatching is usually more severe than what we see in hypoventilation. High flow oxygen can increase that diffusion gradient and raise the O2 levels. But by doing that, we can slow the respiratory rate of our patient, and that can lead to further increase in CO2 retention. So we usually don't try to push a COPD patient's O2 levels up really high. We try to leave them maybe around 88 to 92%. they still probably get adequate diffusion of oxygen, um, but then they still have enough kind of respiratory rate or ventilation to keep that CO2 retention from climbing. We'll talk about the signs and symptoms of CO2 retention momentarily, but they can lead to things like acidosis. And often what we see symptom wise in a patient where this is happening is a lot of like maybe sleepiness or difficult to arouse. Okay. Impaired diffusion is another cause of hypoxemic respiratory failure. So in these patients, there's something that's causing an increase in distance for diffusion or a decrease in the permeability or surface area for movement of gases. So this is the type of respiratory failure we usually see in patients with ILDs or ALI-ARDS. We also see this in patients with pulmonary edema and pneumonias because they have so much kind of uh, fluid or exudate formation within the alveoli that's increasing the distance for diffusion of gas. Severe hypoxemia but no hypercapnia is usually what we see here because of the greater diffusion rate of CO2. So again, in things that impair diffusion, it's usually because of an increase in like either distance or surface area. But because CO2 diffuses at a rate about 20 times higher than that of O2, it's usually still able to adequately move itself across those membranes, while O2 no longer can. So again, we just see usually in these cases pure hypoxia without hypercapnia. High flow oxygen can be helpful in these cases because it can help to really increase that oxygen concentration gradient, helping more oxygen move across into the vasculature. The other type of respiratory failure is hypercapnic hypoxemic respiratory failure. And this is really an inability to maintain alveolar ventilation that's sufficient to eliminate CO2 and keep arterial O2 levels in range. So when we talk about ventilation, it really relies on a lot of things. We need good CNS impulses from the respiratory center to drive things like respiratory rate. We need proper air movement through all of the conducting airways, so through the trachea, through the bronchi, through the bronchioles. If we disrupt that ventilation at any of those levels, that can lead to some type of respiratory failure. So things like depression of respiratory centers from drugs or from brain injuries, any disorders of the nerves that supply the respiratory muscles of the chest, or disorders that damage those muscles themselves. So like nervous system things might be spinal cord injury, or damage to the muscles might be something like muscular dystrophy. So those are some examples there. Um, when someone is hypoventilating, as is the case when we have these issues with ventilation, the first thing that we see is a significant and rapid rise in PCO2. And so the best diagnostic tool for looking at hypercapnic hypoxemic respiratory failure is usually rising CO2 levels. Those happen first and kind of most dramatically. Hypoxemia comes second, but because we still have, good surface area for gas exchange, that's really not the issue. It usually that hypoxemia responds really well to treatment with supplemental oxygen. So unlike things like ARDS, which doesn't, this really will. So the clinical manifestations of respiratory failure, there's varying degrees of the amount of hypoxemia or hypercapnia that we see. Respiratory failure is conventionally defined by an arterial PO2 of less than 50 or an arterial PCO2 of more than 50, or potentially both, when any blood values previously taken have been normal. So we say that piece because patients like maybe a COPD patient may have elevations of PCO2 above 50 all the time, right? And so these are patients who previously had normal levels and they've changed. Do know though there's a lot of variation in that. Those are not absolute numbers. There are a lot of other things we kind of have to take into consideration. That's just some kind of like general conventional numbers. Okay. Clinical manifestations. So things like respiratory acidosis when we have hypercapnia, And so then any of the usual signs and symptoms we see with respiratory acidosis would be in play here. Other things, cyanosis, restlessness and confusion, anxiety, delirium, fatigue, tachypnea, hypertension, cardiac dysrhythmias, and tremors. We also get pulmonary vascular constriction because of hypoxemia, and this can lead to right-sided heart failure, especially if this respiratory failure is severe. In cases of severe hypoxemia, we can also get things like convulsions, retinal hemorrhaging, and even permanent brain damage if we can't correct the hypoxemia in a timely fashion. So treatment of respiratory failure, first we have to treat whatever the underlying disease is. Whatever has caused the underlying, or whatever has caused the respiratory failure, we need to manage that, right? If it's a drug overdose, we need to give Narcan. But sometimes those underlying things cannot be managed. So, maybe we have a hypoventilatory respiratory failure from a severe brain injury. Well, there may not be anything we can do in that initial period for that brain injury. So then we have to do some sort of respiratory supportive care to maintain gas exchange and potentially establish an airway. So that might be through things like mechanical ventilation to take over that drive of breathing if someone loses it, right? We can also use things like anti-inflammatory or bronchodilators or mucolytics or antibiotics if the underlying cause has something to do with inflammation or fluid within the airways. But our overall goal here is to ensure that we've got adequate oxygen delivery to the organs. That's kind of the number one thing we need to manage in respiratory failure. We have to somehow work through a way, based on whatever the cause is or what we need to manage to make sure we're maintaining oxygenation of the tissues.